Great. Welcome, everyone. I'm delighted to see so many people here. So warm welcome from on behalf of LSE Health to this public event. So health inequalities are deeply rooted, and we know that they are persistent. They are very much affected by early life determinants, socioeconomic determinants, geographical, gender, race, and other determinants. And I'm sure that you will learn a lot from today's seminar. To speak to this question on health inequalities, I'm delighted to introduce three speakers who come from different disciplinary backgrounds. We have Maarten Limbedom, who will speak in a minute. Who's an economist and a professor at the University of Amsterdam. Then we have Julia Lynch, who's a political scientist and a professor of the University of Pennsylvania. And then we have Jennifer Dowd, who's a demographer at the University of Oxford. So then this event is all moderated by Emily Corten, who's going to handle the questions later on. So without further ado, Maarten, the floor is yours.
This presentation is about the drivers of inequalities in health later in life, and it is primarily focusing on the start of life, because there is where mostly the differences are made. At least that will be one of the arguments of this talk. I'm an economist by background. That also means that that's what economists mostly do. They can sometimes be a bit techy, and the presentation will at some points be a bit techy, but I think you should just ignore that, and I hope I can explain. And if not, you can just ask me maybe to repeat something or to tell me what it actually means that I'm showing you. It is based on joint work with Joanna Kopitska and Eduardo Di Porto. They are at Sapienza in Rome. And it is about early life and the role of stress, actually. That's what I should mention. So the focus is on stress very early in life. And let me see if I can move on to the next slide. Oops, I don't see my... Sorry. This makes clear that I'm a boomer. I cannot see my... I managed to do this. But okay, the idea is actually, that's the background, that there is a recognition that health and socioeconomic outcomes and inequalities have their roots very early in life. And it started more or less, I think that's one of the initiators, is Barker, the Barker hypothesis. It's basically the idea that very early in life, maybe in utero, adverse events or adverse conditions may affect the development of the organs of the unborn child. And as a consequence of that, it may affect also later life outcomes. So the start could be something like a biological process that does harm to the body of the unborn child during pregnancy, and then later in life, people actually get worse health outcomes. And with worse health outcomes, often also worse socioeconomic status outcomes. And besides, let's say, the direct biological link, that's by Barker, there are also pathways models that suggest actually that when there is a bad start in the beginning, education may be hampered, and education, again, may have an effect on health, and this may also affect, again, let's say, the final education that you receive and also your labor market outcomes, etc. So it could be a chain of events. And I'm not going to focus on the specific mechanism from early life, what happens at the age of 10 or 20 or 25. I'm just going to focus on, here in this talk, on the very first parts early in life. But let me continue from what economists have done. Economists actually, what they mostly do, I think, they use very good ideas from epidemiologists and from medical sciences and from the demographers. And then, of course, we as economists try to give it our own flavor. And often economists are a bit, well, I think a little bit blunt in the sense that we think we can do it better. I'm not sure that this is the case, but anyways, let me proceed and you can judge on later. Yeah? But the start early in life is important, also from a scientific point of view, to see indeed if there is a relationship between very early in life and later life health outcomes, but also from a policy point of view. Because if indeed at a very early in life things happen, then interventions very early in life can be more beneficial, if not only because the benefits are reaped over a longer period of time. And maybe if things go wrong in the very beginning, you could sort of circumvent deteriorations in childhood and maybe in early adolescence, rather before people enter the labor market. Now, this assessing effects, and economists are obsessed with causal effects, is not a trivial exercise. So let me give you an example. Most studies actually in this discipline, I think also demographers and epidemiologists and early economist studies also used birth weight as a proxy. The idea is that birth weight is a proxy for the intrauterine environment. If there was an adverse event or if the conditions were not well, then it would translate itself in a lower birth weight. And the lower birth weight may be related to worse labor market outcomes. And that's indeed what the early studies found. However, there is a problem with confounding. There is an association rather than a causal effect. Because you can imagine there could be other circumstances, for instance, genetics, that may have a relationship between later life health of the mother and of the child. And in that sense, there may be a relationship between early circumstances, low birth weight, and later life outcomes. So what we mostly do in economics, we try to find something like exogenous variation. So we will try to find something that shocks the early conditions, the conditions very early in life, that is independent from the decision of the parents or of the decisions of the child at later ages. And we call that natural experiments. Loosely, something may happen in the context. Let's say there can be an epidemic. And in this epidemic, the conditions for childhood, where the child is in utero, may be affected because the mother could be infected. And for that reason, the child may have a worse outcome. Or, for instance, in the times of a famine, people may live in a certain area, there is not enough food. The pregnant mother may also have less food, and this will translate itself to the development of the fetus in utero. And when the child comes, at birth, there will maybe a lower birth weight, and consequently, there may also be worse outcomes later in life. And there may be something like traumatic events, like wars, things like that. And that's actually what the literature has done most of the cases in order to assess whether or not there is a causal effect. Somewhat more precisely, let's take an example of the famine. If people are born in an area that has a famine, you can compare these people who were born in an area where there was a famine at present. You can compare this with children who were not born in that area. So basically, you have some sort of a randomization, and the randomization is caused by the famine. And the idea is that people cannot make a decision about the famine in itself. This is something that happens to them. And if you have something like that, then you can, and you find an effect of exposure to famine very early in life, then it may be, let's say, evidence for a causal effect of malnutrition on later life outcomes. And these shocks are convenient when they are very, when they are very early in life, and if you want to assess the effect on later life outcomes, but then you need, of course, a long follow-up. So it also means that you have to follow people over a very long period of time. So it also means that these shocks, which are generally very big shocks, a famine or an epidemic, or let's say a war, and these effects, are extremely big, not sort of a moderate shock, what we normally face in life. And we would be interested in seeing the effects of these as well. So there is an issue of external validity of these historical events. Do they still hold today? And if they are so big, is this something that will happen still today? Unfortunately, I have to say that it actually will, because you could see this in Ukraine, for instance, or in the Gaza area, where now there is a war going on. There exactly the mothers who are pregnant of children or children at very young ages are most likely affected for a longer time period, and this will have an effect on the later life outcomes. But we would like to see, actually, from a scientific point of view, more evidence for modern, nowadays, shocks that are not so big. A limited shock. For instance, when people are fired from their job. That might be a very limited shock that affects people normally in life and what might have an effect, actually, on the birth outcomes of children and the later life outcomes. And for that, I focus to ongoing work with Joanna Kopinska and Eduardo Di Porto. And it is, well, this is a professional title because it's not a paper yet. This is just a presentation. And it is the effect of firm downsizing. So in a nutshell, in case I run out of time and the chair, Johan, will tell me to speed up, if there is a mass layoff at a firm, people are fired normally. But people who are pregnant, women who are pregnant, cannot be fired by law. So the idea is, if they cannot be fired by law, that they will still be exposed to the stress surrounding, where there is a lot of disturbance in the firm, where a lot of people are fired. The woman who is pregnant at that point in time cannot be fired. And yet, of course, she may be exposed to the stress that is present in the firm at around that time. And what we then do is look at the birth outcomes. First, at how much this stress associated with this firm downsizing of moms that are in the firm experiencing a mass layoff. We look at the gestational age, whether or not there are preterm births. And preterm deliveries, preterm births, are often associated with neonatal health, and worse neonatal health is also again associated with later life health outcomes. So that's in a nutshell what I will be talking about. So indeed, losing a job, and now somewhat more lengthy, losing your job is a stressful event and it can affect on individual well-being. We also know that losing a job affects future employment outcomes more often. It affects your income. It also often has a mental and a physical health effect. But recent studies have also showed that those who do not lose employment in a mass layoff can still suffer from a layoff. And this is recent work by Ahammer, Grubel, and Winter Ebner, an Austrian study. I think the study is from 2021, but I think it is recently published in a Review of Economics and Statistics. They show that in a mass layoff, those workers who remain in the firm, males and females, pregnant or not, still there is effect on their health. It is because of the psychological stress, they find, let's say, that the care utilization increases actually of these remaining workers in the firm, and that these effects are particularly strong for women. That for women there is a 58% increase in heart attacks due to ischemia, and ischemia is a reduced blood flow to the heart. So stress may lead to high blood pressure during pregnancy and problems to the mother, but it also leads probably, or most likely, to premature birth and low birth weight infants. And indeed, clinical research on birth outcomes has shown that stress hormones, cortisol and CRH, have negative association with the stress hormone levels at birth and birth outcomes. So there is a reason to suspect that the stress that the mom experiences during a layoff can have a direct effect on the birth outcomes. And besides that, there could also be some kind of a trauma stress of the mom, and that could affect her parental skills, and in turn may also affect how a child develops later in life. But let's just focus on the direct effects. We look at mass layoff within firms, and we look at the birth outcomes and neonatal health and cost. And indeed, it is nice, or not nice, but pregnant women cannot be fired. So we have a situation that something is basically thrown upon pregnant women without their own control. Something happens with the firm. They're experiencing a very stressful environment, and this may have an effect on their outcomes. And we do this with very detailed administrative data. We have data that cover the universe of private sector workers. And these private sector workers are all linked to the firms where they work in. And in this private sector data, we observe wages and job characteristics and how many hours they work, but we also observe maternity leave records. So we can observe, and also birth records. So we can observe the condition of the child, or at least whether or not the child was premature. We can observe that in this data set. There is also another data set, this is called the CDEP data. This is the universe of all births in Italy. This is Italy, I may not have mentioned you before. But this CDEP data set also has data on information on gestational age, also delivery outcomes, stillbirth, birth weight, APGAR scores, and all these kinds of neonatal health outcomes. And we also have a hospital data discharge data set that actually gives, let's say, the medical cost associated with birth outcomes. It would be ideal if also we had information in the second and in the third data set where we link the mass layoff data directly. In that sense, if that would be possible, we would have a mass layoff, we would have the premature birth, and consequently also birth outcomes. We cannot have the causal chain directly, so we have two sets. We first do the first data set to look at premature birth, and then in the second and the third data set, we look at conditional on premature birth, what happens to the birth outcomes. We cannot link both data sets. We hope to do this later. So what is new or what is nice? Maybe I can be very brief on that. We know that premature birth is related to birth weight, and birth weight again to later life health outcomes. There is very little work actually that identifies in utero stress directly, because often it is associated with other things that are going on. People lose their job, so their income drops, or there may be other things, violent things happening on, so more than stress only. And in wars, other things may go on. There may be stress, but also, the healthcare system doesn't work. So there can be other reasons for adverse outcomes at birth and also later life in time. So what is nice about this study, I think, is that we have a common and a very moderate stressor. It is something that is not really very, very big, you would say so, right? I mean, of course, you are in a firm that experiences a mass layoff, but the mother is exposed, or the potential mother is exposed to the stress. She's not losing her job. It is precisely measured at what time the child was expected to be born and what the actual date of birth is. So we can measure how much premature the baby was born, and the stress, or at least the shock, the adverse event, is actually very precisely measured, and it happens to all workers in the firms. So what we say, the economist, the shock is not something, that only covers part of the population, or it covers all the people in the firm, which is different sometimes from a famine. If you use a famine, then you know that people in an area may be affected by the famine, but you do not know exactly whether people sometimes lived on the countryside, or whether or not they had stock or food available. But this is important because it also facilitates the stress interpretation. So we can be pretty sure that if we find something here, stress is most likely to be the most important mechanism. We also have, and we do not use it so much in this presentation, we can link the mothers and the fathers, and also can find what happens with the father's income. If the father loses his job, or if the father is in a firm, actually, that also faces a mass layoff. So there is the data set, the first one, the INPS data, the universe of Italian workers in the private sector, 2010 to 2019. We have date of birth, municipality of birth, and age of death. We have labor market records, and we have matched firm and worker information. And we can identify firms, and we identify firms that are relatively big. 25 plus workers, and we define a mass layoff as having at least 30% reduction in the workforce. And we can match these firm mass layoff episodes with maternity leave records. And with the data set, these objective certified data, we can define preterm indicators. Gestation shorter than 37 weeks, shorter than 32 weeks, and shorter than 28 weeks. We also have pre-birth leave and other parents identifier, but for this presentation, I do not really use this. This is descriptive statistics. How much time do I have, Johan?
You have about 7 minutes.
Oh, then let me speed up. Well, let's say that I have numbers. That's what this table tells you. I have numbers with preterm births. That's what you see here. And in different classes. And the mean are around between 5% and actually 1%. This is, I skip this one, and I skip also this one. Basically, this is the distribution of the gestational age for different age categories of the mom. So the pink one in the beginning is for very young moms between 15 and 20, and the last one is between 41 and 45. I will skip this, but basically this plot here is to show you, because what's important, that the shock of the mass layoff comes with a surprise. It should not be the case that women leave the firm prior to the mass layoff. If that's the case, what remains as women in the firm is a very selective set, so that we cannot make general statements about this. So this is basically upshots of the 4 pictures here. Then there is an empirical model. Don't try to really look at the exact specification, but basically it's what we call a Poisson model. This is a statistical model that what is mostly used in the statistics for rare events. If events do not happen a lot, then people mostly use a Poisson model. And this in yellow, this beta 1, is the effect of the mass layoff. That's what I'm interested in. And I have a lot of controls, characteristics of the individual, and also characteristic of the firm of the individuals. There is a firm-specific effect, there is a month of birth effect, there is a year effect, etc., etc. And what we then can do is we can look at women who are in a firm that faces a mass layoff. So we can compare the outcomes of these mothers who are faced with a mass layoff during pregnancy with the outcomes of mothers that are not in a mass layoff. These 2 firms may differ. These may be different firms. So that's why we have strategy 1A. We can try these firms as much as we can comparable. So we look at more or less twin firms and compare the mothers from twin firms with the firms that haven't faced a mass layoff. Very similar firms. And the second or the third strategy, this is strategy 2. What we can do is we can only focus on firms that face a mass layoff and then look at mothers who gave birth to a child prior to a mass layoff and compare them with moms who gave birth to a child during the mass layoff. So that is another strategy to make sure that the results are more or less trustworthy. Preterm birth. I have the arrows at the mass layoff outcome. I did this because I would expect that I would run in time problems, but we have it for different gestational periods, less than 37 weeks, 32 weeks, and 28 weeks. The stars or the asterisks denote significance. So if the asterisks are 1, if there is 1 asterisk, it means significance at the 10% level. If there are 2 asterisks, it means significant at the 5% level. And if there are 3 asterisks, it means significance at the 1% level. So basically, you would see that the larger part of these effects are on gestational ages shorter than 32 weeks and shorter than 28 weeks. We also do this by household income. We look at household income where the income is, let's say, above the 50 percentile or below the 50 percentile. So this is HI, I don't see my own cursor, but HE means high income, and HE is 0 means low income. So you would see that the effects of a mass layoff is not present for families that are well-to-do. Let me put it in this way. Well, does it really matter? So we find an effect of the mass layoff on preterm birth, lower than 32 weeks and lower than 28 weeks. Does it matter? Then again, as I told you earlier, we have two data sets, one with neonatal health outcomes and one with hospital cost. This is the association between preterm and birth outcomes using the CDIP data. You see here on the vertical axis, you see neonatal outcomes. So here is the UPCAR score, for instance, and the 0 here is the effect. So it means if it is close to 0, it means there is no effect at all. If you see it here, it is negative. So it means actually that once a preterm baby is there, the UPCAR scores are much lower. And actually, you would see also that there is a lower possibility of a natural birth when there is a preterm birth. Also, the height of the baby is a bit smaller, but importantly, what you see here is extreme outcomes. So if you look here, oops, I missed my cursor. Yes, well, you cannot see it. These are outcomes associated with abnormal head circumference, low head circumference, abnormal height or very low height, and extreme low birth weight. So you would see that premature birth is associated with worse neonatal outcomes. So that's nice, or not nice, but actually that's what you would expect. And then there is finally, we also look at neonatal hospitalization cost. So in table 37, we have the cost at the minimum. The minimum is, it means there is no premature birth. So it means basically you deliver a baby in the hospital at 40 weeks. It will take some money. And sometimes there are more costs associated. And sometimes there are very large costs associated. And also the hospitalization length varies from 0 days. So it is basically you go into the hospital and you leave the same day, or you could actually stay for a couple of days in the hospital with associated costs that are much lower, much bigger. We see also here, this is not premature in general, but the logarithm of or the low gestational age. I think it is less than 37, not sure. We see the annual cost for a premature birth is 4,600 euros per year. And it actually boils down per year, if you do it for all the costs that are associated with that, to approximately, that is what in this here, approximately 230 million euros. So what we find an effect of a mass layoff on premature birth. We also find that this premature birth is related to extreme low birth weight, to low UPCAR scores, to UPCAR scores less than 6 or less than 4, which means that the doctor should be involved, or even a medical intervention. We also see that the number of births is associated with approximately, there are approximately 500,000 babies born per year. And if there is preterm birth, is approximately 7.8%. And it boils down to extra medical cost of approximately 230,000 million euros. That's it.
Our next speaker is Jennifer Down. So go ahead, Jennifer. You can share the screen.
All right, thanks for having me. This is an exciting group to be a part of. I'm going to use my time to talk a little bit about differences in health across countries. I've done a lot of stuff, a bit more like what Martin was talking about at the individual level in the last few years, have gotten really interested in trying to understand population level trends a bit more. So I'm specifically going to talk about lagging US life expectancy. And because I know we have an interdisciplinary crowd here, and life expectancy is probably one of those terms that you hear a lot in the news when different estimates come out. And you might have some intuitive sense of what it means, but I think it's helpful to kind of just define what demographers mean by life expectancy. Because I think a lot of people think it's how long am I expected to live? But in reality, life expectancy is not a prediction of the lifespan of any one person. It's really a snapshot of current mortality conditions in a population. So we calculate it as the average number of years that a baby born today would expect to live if they live through the age-specific mortality rates that are happening in this year. So it assumes lots of things, that mortality rates wouldn't change. So it's really not meant to be a forecast of the future, but telling us about the mortality conditions in the year in which it's measured. And so you can look at these numbers from that lens. You can see that life expectancy in the US has been falling behind peer countries really since 1980. And if you can see the little gray lines in this figure, those are individual peer countries. Usually, I think these are OECD, other high-income countries. You can see that the US, is really falling out of the pack in recent years, even before COVID. So not just below average. And this gap in life expectancy was around 1 year in 1980, but then close to 3 years just prior to COVID pandemic. And I wanted to talk about that because some of my colleagues in the US who have brought, these seemingly alarming numbers to policymakers at the state level, have gotten some pushback that, well, is 2 to 3 years of life expectancy really important? And I think that's because they often think about that as we're extending people's life from, living till 78 until living to 80. And maybe that's, not a very big deal. Maybe it's not something we want to sacrifice our freedoms for or spend more tax money on. And when I heard those stories, it really struck me that life expectancy is possibly not a great metric for us as mortality scholars to communicate kind of the urgency of things that are going on and what these gaps in life expectancy really mean. And I also learned that during COVID, when we saw big drops in life expectancy that were kind of temporary, that this is really not an intuitive measure. So I wanted to present these numbers in a couple of different ways to kind of bring home what's really underlying a 2 to 3 year difference in life expectancy. And so, of course, life expectancy being 3 years lower in the US compared to peer countries means, it's not 3 years for everybody. It's an average. So it really means that a lot of people are dying prematurely by much more than 3 years. And Jacob Bohr and colleagues estimated a counterfactual that I thought was a really clever way to communicate this. They kind of calculated how many Americans would have been alive between 1980 and 2019, how many more Americans if the US had had the mortality rates of the average of peer countries. And they calculated in that counterfactual scenario, 11 million missing Americans, as they called it, over that period. And, I thought, again, from a kind of communication standpoint, that was probably a more effective way to get across the magnitude of what's happening with those divergences in life expectancy. And again, what I found stunning about this too is it's, assuming that the US had the average mortality rates of the average of peer countries, not even the best performing. So this is an eminently achievable mortality rates. And if 11 million missing Americans is still a little bit abstract, I think another interesting way to look at it came from John Byrne-Murdoch from the Financial Times, who does some great data visualizations and did a long piece on this within the last year or two, I'm not sure. And I think, we can all agree that, no matter if we want to add a couple of years on to the end of life, we really want our kids to have, the best chance of making it to older age in the first place. But what you can see here is that 1 in 25 American 5-year-olds today will not make it to their 40th birthday. And that's closer to 1 in 100 for peer countries to the US. And so that, I think was a really striking statistic too, meaning that every, one set of parents in every kindergarten class in the US will actually have to bury a child before the age of 40, which is really awful. And this represents, of course, what you might expect, a lot of external deaths. So firearm deaths have taken over from car accidents as the leading cause of death in American children and adolescents. And then obviously in middle age, there's other things going on. But this picture, I think, is really the crux of, the American shortfall in life expectancy. It reflects a lot of people dying way younger than they should, and not just a couple of years taken off at old age. So that's kind of what I want you to take home from that. And I'm not going to dwell too much on this, but we might discuss it later. A really important feature of US mortality right now are sizable and potentially growing socioeconomic inequalities in health. And Ann Case and Angus Deaton, who I'll mention again in a second, have highlighted that this worsening mortality profile is most notable for Americans without a college education, which really is the majority, around 65%. And so you can see this gap growing over time, and that the stallings and reversals, even prior to COVID, are very concentrated in this group. And this is true for income distribution as well, even though, and I thought this was another striking figure from John Byrne-Murdoch, even though incomes are considerably higher in absolute terms in the US compared to the UK, for example, it's really only the top 1% of the income distribution in the US that may be approaching similar life expectancies to the same relative spot in the income distribution in England. And you can see that gap at the bottom of the distribution is really wide. This is a characteristic of the US. We seem to see lower levels of health, not only lower levels of life expectancy, but steeper socioeconomic gradients. And the obvious implication is that there seems to be something even more costly to health about being disadvantaged in the US compared to other high-income countries. And as demographers, we've done, I say, a lot of work on trying to understand the what of, what's going wrong in the US, and, where are these deaths happening, what ages, what causes of death. So we do a lot of description and decomposition and trying to understand the patterns. And so I can assure you there's been a lot of research attention to this falling behind in the US. And it's, it's a very complex problem with no easy, simple stories, despite, I think, what RFK Jr. wants to tell us. But to highlight a couple of things that we know is going on with US health disadvantage, it's clear that mortality at working ages, kind of midlife, is very different compared to peer countries, and it's getting worse. So in this figure, you can see over time the relative ratio of mortality at each age in the US compared to the average of peer countries. And just that red line being the most recent estimate in 2016, you can see how much bigger that excess kind of relative ratio of mortality at younger ages has become in the US over time. And there's been a lot of investigation about what causes of death are contributing to this US disadvantage. And of course, Ann Case and Angus Deaton wrote some influential papers and a book a few years ago entitled Deaths of Despair. And this was a constellation of causes due to alcohol, suicide, and drug overdose. And Case and Deaton attributed the rise in deaths of despair to the long-term decline of stable, well-paying jobs for working class Americans, particularly men without college degrees, due to deindustrialization. And they proposed that this economic instability led to a loss of identity, purpose, community, which were all tied closely to employment. And they call this a loss of dignified and meaningful lives that provided fertile ground for kind of this, what they call abusive self-soothing and turning to alcohol and substance abuse. And this, I think, was a really compelling narrative at the time. It came out around the time of Trump's first election and his kind of popularity in some of these deindustrialized areas. So there's a lot to say. There's been a lot of empirical work on this. And just to summarize very briefly, I'd say the evidence for deaths of despair as the main driver of lagging US mortality relative to other countries isn't really that strong. So, despite stimulating a lot of research, these three different despair causes, alcohol, drugs, and suicide, don't really move together across time and space in the US, in a way that suggests a coherent underlying cause. But what has really been clear is that the opioid epidemic, drug overdose epidemic, is largely responsible for these trends. And here in this figure, you can see this red line is US mortality from drug overdoses at different ages. And it's just kind of head and shoulders above the UK or other peer countries. So the levels are just kind of staggering. And that, has been really attributed to a period shock that started with prescription opioids and then, pushing of more dangerous street versions as restrictions on prescriptions happened. So it seemed to be something very specific to opioid marketing and, a lack of regulatory oversight of these particular drugs, et cetera. And, so that's not to say that there wasn't a demand side to the drug epidemic, but it seemed, very specific to the opioid crisis. And so despite all the attention to that terrible scourge of drug overdoses, empirically, especially looking across countries, a much more important contributor to lagging US life expectancy comes from, not surprisingly, the number one cause of death, which is cardiovascular disease. And in this paper by Neil Mehta and colleagues, you can see this red line that, the number of deaths that happen from CVD kind of just dwarf drug-related causes, which are at the bottom. And so this divergence in life expectancy really comes from this stalling, that red line kind of flattening out compared to continuing to go down in other countries in the US. And of course, why is that happening? That's, very much an open question. The obesity epidemic is one important hypothesis that, it started first in the US and has risen to really high levels. And so we now are kind of getting to the point where we have generations who have grown up obese, who are reaching middle and older ages with much longer durations of obesity. But this is kind of a very active area of research, trying to understand what's driving the stalling improvements in cardiovascular disease mortality.
5 minutes.
Sorry?
5 minutes. Sorry.
5 minutes. Okay, great. So obviously these trends are concerning, and for many years, social scientists and demographers have been trying to call attention to why is America so unhealthy. So it does seem somewhat ironic that this is a focus of attention finally in some policy circles, but possibly not in exactly the way that we hoped. So I'm not sure that what's happening right now with Make America Healthy Again is the right approach. So I'm going to talk about kind of things that I think are more enduring challenges to understanding and then intervening on this population level trend in the US. But I think maybe Julia will be talking about some of these, so I won't go on too long. But obviously, I think, a reason this has been hard to address in the US is that the causes of population health and mortality trends are very complex and play out over many decades. So, things like smoking, improvements in smoking have taken decades to play out. And in the other direction, the obesity epidemic probably is taking decades, to show up in these other trends. And we know that that's not a function of, genetics having changed. There's something obviously in the environment that has made it very difficult for people to not be overweight or obese in the US. And another thing that some of my colleague Ryan Masters, who works a lot on US mortality, has pointed out is the US political culture of shifting risk to individuals. And there was a book by Jacob Hacker called The Great Risk Shift that kind of talks about policies, economic security used to be more supported by institutions in the US, employers, unions, but that risk has gradually shifted. And I think we do a lot of the same with health risks. If you think about pharmaceutical regulation, gun safety, road safety, and then vaccines and mask mandates, there really is this tension between structural determinants of health that we know are important, but placing a high cultural value on personal responsibility and libertarianism. So I think that's an ongoing challenge. We know that healthcare access is a very difficult political and economic issue in the U.S. The U.S. is also, different from the U.K., for example, in having a wide variation of policies across states. Something I've been thinking about is, if despair or this kind of increasing hopelessness and challenges to mental health are important at the population level, how is it that we might think about policies that can address that? And then finally, something that, has really, as someone who worked intensively on COVID, really become salient to me is the increasing politicalization of public health and right now kind of an attack on science and erosion of trust in these institutions. And that was seen, very clearly during COVID. We saw a very strong association between vaccine uptake and political partisanship in the US, with excess mortality among Republicans emerging after the vaccine rollout, which is just really tragic. And that this was actually pretty unique to the US as far as partisanship or political leaning being so strongly associated with vaccine uptake. It wasn't seen, either at all or very strongly in Europe. And just towards the end here, I'll just throw out, while there's been a lot of focus on poor trends in US life expectancy, one thing we've been working on is looking at what's happening in the UK. And the UK is unfortunately trending poorly as well, especially since 2010. And this, you can kind of see this as falling behind. The tail of the arrows were 2010, and then the right side of the arrow is 2019. And there's a lot of improvement in other countries in Europe, but not so much in England and Wales. So there's been a divergence. We did some work trying to, again, understanding the causes of death and ages that were causing this divergence of the UK from peer European countries. But just to sum that up, it actually was a bit parallel to some patterns in the US with stalling improvements in cardiometabolic disease and also external mortality. Not as much of a drug overdose, but compared to other countries that saw continued declines in external mortality, those improvements kind of have been stalling in the UK. Alcohol mortality is one that's also stalling. And sorry, I'll just say, it's interesting to me that, the focus in the US on despair has really been thinking about these, long-term cohort changes in economic opportunity. In the UK, the conversation has been a lot around the effect of austerity cuts around the financial crisis in 2010. And so it's interesting that the narratives are very different, but I think there's a similar challenge in really trying to understand and empirically test what's going on to cause these changes, especially in stagnation and mortality improvements. I'll skip this, but there's some suggestion that we're also seeing generational health drift in the sense that people are less healthy than older generations at the same age. And so that's something that we're looking into. And overall, kind of taking stock of lots of different trends, I had to write a review paper, which I'll show you in a second. But one of the things I'm thinking about is, are we entering a new period of kind of pessimism of mortality and health trends? At least while I've been studying demography, we've known that, we've had this upward march of steady progress that's been remarkable in life expectancy gains. But, what would it mean if those consistent gains were not to be expected anymore or even move in reverse? And I gave some reasons for pessimism in the US, but I also think there are still reasons for optimism. I like to be optimistic. Certainly technology and medical improvements continue. I'm very interested in the new GLP-1 medications like Ozempic. High achieving countries that are doing much better than both the US and UK in life expectancy show us that this is possible, and we haven't met a biological limit yet. These are really human-made limits that we're bumping up against. So if you're interested in digging a bit more into that, you can please take a look at this review article where we kind of think about all of these different mortality scenarios. And I'm also trying to do a bit more general writing on both demography and health topics. So if you're interested, please check that out on Substack. Thank you.
Both the previous speakers were fascinating talks, and I'm sure that Julia Lynch will be too. So Julia, go ahead. Floor is yours.
Those were two fascinating talks. Thank you both so much. I learned so much and really excited. So I'm going to talk today about work with Claire Bambra and Catherine Smith. We recently published a book called Getting Better, The Policy and Politics of Reducing Health Inequalities. In a bid to inject a little bit of the enthusiasm and optimism that Jen was just calling for. So most health inequalities research has a little bit of the flavor of the two presentations that you just heard, in focusing more or less on negative findings, not in the sense of not finding what you expected, but in the sense of finding that things are pretty bad for a lot of people. Health inequalities are very often viewed as wicked problems that aren't amenable to the same kind of normal policy making that some other more tractable problems might be amenable to. Health inequalities are often seen as more like climate change, big, complex, really difficult to solve. Another reason why we tend to be very negative when we talk about health inequalities is that governments, even when they try to reduce health inequalities, very often fail. One reason for that people have hypothesized is that there's not a great evidence base for what you could actually do to reduce health inequalities. We have a general sense, but there's not a lot of really hard evidence, mainly because it's very hard to measure the kinds of effects and interventions that we think are most likely to reduce health inequalities. And all of this we view as contributing to a kind of political paralysis around reducing health inequalities. But we wrote this book because we think that there are reasons for optimism. We think that it is possible to reduce health inequalities. First of all, the evidence base that's out there is a lot broader than the sort of narrow kinds of evidence that are often taken into account in things like systematic reviews. So systematic reviews of literature tend to prioritize randomized controlled trials, very strong causal inference of the kind that Martin was talking about earlier. And we don't always have that kind of evidence about health inequalities, but we have a lot of other kinds of evidence, which when you add it all together, may give us a little more reason for optimism. So if we can be a little more flexible about what we think about as high quality evidence, maybe we can muster a little bit more optimism. A second reason that we think we could be more optimistic about the chances of reducing health inequalities is that many governments have actually done it. While it's true that many governments have failed, it's also the case that governments have succeeded when they've tried to reduce health inequalities, at least temporarily. And so I'm going to show you a few examples of that. We think that sharing these positive examples can not only sort of make us more cheerful, but can actually support policymakers in having the confidence to do things that they otherwise might be worried about doing because they're not sure that the evidence is there, or they're not sure that it's going to work. And so we really wanted to share some optimistic examples of places where governments have been able to reduce health inequalities. So what we did in Getting Better is we looked at 4 case studies of governments that successfully reduced health inequalities. Not all health inequalities, they didn't reduce them permanently, but they managed to, by dint of policy change, reduce some inequalities across relevant social divides in their countries for some reasonable period of time. And so the 4 case studies that we look at are the Great Society in the 1960s in the United States, democratization in Brazil, which started in the mid-1980s and continued through the 1990s, German reunification after 1990, and the health inequality strategy that was introduced by the new Labour government in the UK in the decade of the 2000s. So just for the nerds in the crowd, a note about our methods. So we selected these cases because all 4 of them are demonstrations of possibility. And we were simply interested in how it happened in these 4 cases that governments were in fact able to reduce health inequalities. We've all studied a lot of examples of governments not being able to reduce health inequalities, so these were really striking examples for us. So we just wanted to know, how did it happen? And so as a result, these case studies, we didn't select them to be generalizable to all other settings. But we thought that by looking at these cases, they might provide some ideas for policymakers in other contexts about where to start. At the same time, we did take a very structured approach to these case studies. So they weren't sort of random cherry picking. So I want to just give you a little bit of insight into how we conducted these studies. So the first thing that we did is we looked for any specific policy changes. So like laws, right? Policy changes, quite specific things that we knew from our theories of health that they could possibly affect the known determinants of health: social determinants, political determinants, economic determinants, et cetera. Then we did a very broad scan of the literature to see whether the distribution of these determinants of health across relevant social cleavages in society changed as a result of these policies. Then we looked for literature assessing whether there was a causal impact of these changes in the distribution of the determinants of health on changes in health inequalities. So we're really like trying to, as best we can, cement kind of the causal links in the chain using literature by folks like Martin and Jennifer, economists, demographers, epidemiologists, policy scholars, to try to connect sort of the links in the chain to make a plausible argument that there's something causal linking the policy changes to the health outcomes that we see, even when we don't have strong direct evidence of that. Where no causal assessments are available, we estimate the likely effect of these policy changes on health inequalities based on the causal effects that have been observed in other similar contexts. So what we want to do is be fairly careful about drawing inferences about the results of policy changes, but at the same time, we don't want to rule out the idea that there are effects simply because there wasn't a randomized controlled trial or because economists haven't found like a nice natural experiment. Okay, so our first case study is the Great Society, and I'm just going to go through these 4 case studies very, very briefly to just kind of give you a flavor of it. The Great Society involved a massive change to the welfare state in the United States, the sort of largest welfare intervention since the New Deal. It also involved a lot of political change, mainly in the form of civil rights and voting reform. and also changes in regulation of the labor market that provided very favorable effects for people at the low end of the labor market and also for women and non-white workers in the United States. So there are a lot of policy interventions going on at the same time. If any of you are policy intervention people, you will know how complicated that makes it to assess the effects. But very briefly, what we found is that a combination of these political and civil rights changes, the welfare changes, and the labor market changes does seem to have resulted in pretty favorable developments, both in terms of racial inequalities in health in the United States and in terms of socioeconomic inequalities. So this is a kind of complicated chart, but what it shows you, just to sort of orient you here, we're looking at premature mortality rates, so deaths under age 65 in the United States. And broadly speaking, they're kind of declining for everybody from 1960 to 2000, which is good news, right? And exactly what we would expect to see. The solid line sort of in the top part of the graph are the non-white population in the US, and the dotted lines at the bottom of the graph are the white population. So what we can see is that broadly speaking, premature mortality is decreasing faster for racial minorities than it is for the white population in the United States, particularly in that period from about 1960 to 1975, when we see the Great Society programs having their strongest effect. The individual lines within each set represent the income quintile at the county level. So it's counties divided by their average income, identified by their average income and divided into 5 quintiles. And it's a little less obvious what's happening here, but just briefly, what we think we're seeing is, again, faster decreases in premature mortality at lower income levels among both Black and white populations. So there's good reason to think, and this is just one indicator, there's good reason to think that the massive changes of the 1960s and the Great Society in the US actually did have an impact on health inequalities. Similarly, democratization in Brazil brought about massive changes, both political changes in terms of rights of democratic participation and rights to join a labor union without repression, things of this sort, but also expansion in welfare programs, a major healthcare expansion in Brazil, which allowed very poor people to access healthcare, often for the first time, and particularly later in the period, a very strong leadership role played by Brazil in taking on some of the big commercial determinants of health, especially tobacco, but also vaccines. So again, a really broad intervention with very central sort of political mechanisms, both the ability to organize labor, the ability to participate in politics, but also things like participatory budgeting. There were many, many areas where Brazil kind of introduced more political participation and input, particularly from poorer members of society who had not often been consulted in the past. And again, we see some suggestive evidence. This is on the left, infant mortality rates, and on the right, life expectancy at birth. Comparing the lowest income quartile municipalities in the dark gray bars to the highest income quartile municipalities in the light gray bar. Again, we see infant mortality, the inequalities in infant mortality by municipal income narrowing substantially from about 1990 to 2010, and also narrowing of life expectancy at birth between those richer and poorer municipalities. So the third case study we look at is German reunification, which is a kind of a different story from either the US or Brazil, which sort of massively expanded the welfare state for everybody for the first time. East Germany had a welfare state. It was actually quite an advanced welfare state in the 1950s and 1960s. But by the time unification came about, the East German welfare state had really deteriorated. Healthcare was underfunded. Access to nutritious foods had become much more difficult. There were just a lot of things that were going wrong in East Germany by the end of the sort of period of separation of the East and the West. German reunification led to, of course, an expansion of democratic participation again for East Germans, but also very important financial transfers to East Germans, which made a lot of people a lot less poor, particularly older people who weren't working. So pensions increased in value massively post-unification. And also there were a variety of other changes that occurred, including environmental regulations, which had been very problematic, a lot of heavy industry in the East, and a lot of health problems resulting from that, housing improvements, better diets due to sort of restrictions on trade, and also starting in 1990, a massive upgrading of the healthcare sector, particularly the hospital sector, in Eastern Germany. And so what we see here, we're looking at life expectancy for men, the dark green bars, and for women, the light green bars. In the East, the dotted lines versus the West, the solid lines. Again, mid-1950s to mid-1970s, the East is looking pretty good. In some cases, you know, men are doing even better in the East than they are in Western Germany. If you were someone who the regime cared a lot about, you were well taken care of. But from the mid-70s through about 1990, people in the East really began to lose ground when it came to life expectancy and a lot of other health indicators. What you can then see is starting around 1990, very rapid increases in life expectancy for both men and women in East Germany relative to in West Germany. There's a really rapid catching up, and particularly for women. So our last case study is the one which I imagine many of you will be most familiar with, and that is England's health inequality strategy, which was enacted between 2000 and 2010. This was in some ways a smaller project than either of the three previous ones, but it did a lot of the same things. So there was massive investment in poorer areas. So in the spearhead areas, the spearhead municipalities that had been identified as most in need of intervention, there were massive interventions. Many, many different policies all coming into these places, and many of them involving community participation. And one thing that I think people in spearhead areas experienced was suddenly a sense that their lives mattered to people in power, which they had not experienced before, or not recently anyway. Sure Start in early years, you know, good investment in young children and in pregnant mothers, investment in the NHS, again, interventions in the labor market, both an expansion of the minimum wage in terms of who it applied to, and also an increase in the minimum wage, and pretty strong interventions in terms of tobacco control. So there's been a lot of skepticism about whether the English health inequality strategy actually worked. Johann Mackenbach had a very sort of famous and widely cited article that came out right at the end of the period, basically saying, look, this hasn't achieved anything. You know, maybe we should just give up. And however, more recent evidence has been collected. You know, I think it's both Martin and Jennifer emphasized many of these things are actually long-term, and it can be very difficult to actually identify improvements of health over a relatively short period of time. But nevertheless, inequalities in infant mortality rates, which were one of the targeted indicators in the English health inequality strategy, actually did narrow between the bottom 20% of municipalities by deprivation and the rest of England. So
We have 2 minutes.
2 minutes, great, perfect. So we've got these 4 case studies. What do they have in common? So we found 4 things that these case studies seem to have in common that were important for reducing health inequalities. One was expansion of the welfare state, at least for some subset of the population who's most in need. 2 is improved access to high quality healthcare. Probably less of an issue in the US case than it was in the things happening in the later time periods when healthcare innovation had led to, more ability for people to get life-saving treatments. Whoops. Oh no. Third thing, reduction of income inequalities and poverty reduction. Really, really important. You do see massive reductions in poverty in all of these cases. For example, the English health inequality strategy, they did not reduce inequality at all, but they did reduce poverty. And finally, enhance democratic participation and political inclusion, which to us really seems like the glue that holds a lot of this stuff together. So, concluding reflections. First of all, it is possible to reduce health inequalities. Don't let anybody tell you that it's not, because it is. Secondly, to do this requires doing a lot, and very often doing a lot all at once without knowing what's going to work, without much of an evidence base. In 1962, when the Great Society started, the US had no social statistics. We had no idea what was going on, but we just did this stuff anyway, right? Because it seemed like a good idea. So go big or go home. Third important reflection is that this progress doesn't necessarily stick around forever. So we look at both the waxing periods and the waning periods of progress in reducing health inequalities. And what we see broadly is that in the waxing periods, the periods where things are getting better, it's very often triggered by broad-based social movements demanding social change, and by ambitious leaders or political parties that have a clear redistributive mandate. The combination of these 2 things very often leads to a popular mood of hope. And so, again, we don't know how to make these things happen, but we do know that these 3 things seem to be preconditions for making things better. On the other hand, things often get worse, and that is very often the case when governments fail to really adequately address structural poverty and discrimination, when ideologies that justify inequality, that sort of push responsibility back off onto individuals, as Jennifer was talking about, become more prominent, and as social divisions that are left as a result of failing to solve structural problems, as these divisions harden and become exploited often by far-right populists, but they could be exploited by other people as well. So we think things can get better. If you want to see the book, it's open access. You can go to Bristol University Press's website. If you actually want a physical copy, there is an event discount, CNF25.
Thank you, and thank you to Martin, Jen, and Joanne and Julia for really great presentations. So we have quite a few questions in the Q&A, and about a bit more than 10 minutes, 12 minutes to go through as many as we can. I'll take them in the order that they appeared. So we have 2 related questions for you, Martin. From Bernard and from Raju, asking about the data that you have used. So Bernard asked, how is low birth rate recorded? Are these corrected for ethnicity, parity, etc., using normative data sets, such as intergrowth 21st, to generate centiles for birth weight? So a question first about your outcome and how corrected or not it is. And in a related question, Raju is asking about low birth weight, in addition to what Bernard just mentioned, was the age of the mother and comorbidity, both obstetric, non-obstetric, accounted for, because these are key factors in premature birth. Over to you, Martin.
Oh, these are good questions, and I wish that my co-author was here, was actually doing the calculations. As to the correction for the birth weight, it is the data set from CDAP, where we have these detailed data, and I guess, or I'm pretty sure that they have these corrected birth weight measures, but I'm not sure whether or not we have used them, right? So I have to check on that. But it's a very important point. We should look at that. And the second question again was about...
So related to that, whether there is the age of the mother and comorbidity, both obstetric, non-obstetric, was accounted for as well in like
Right.
correction
Right.
for that as well in your
no, we do not have that in the data set,
Mm.
but what we do actually is it's more like a randomization. So the idea is that in a way that if these factors may be important, they are distributed equally over those who are affected and those who are not affected. So this is an average effect. So it's, yeah, it is like a quasi-experimental approach.
Right. So those characteristics of the mothers Raju is concerned about should be balanced across the two groups.
Exactly,
Okay.
exactly.
I now have a question for Jen, also from Bernard. What is the contribution of rising obesity to higher cardiovascular disease deaths in the US versus other countries?
Great question. I guess it's been one of the leading hypotheses for what could be going on, but to the extent that people have looked at, and so to try to understand if that might account for cross-country differences, you make some assumptions about the association of obesity and mortality, and then you kind of see whether the levels and change over the years in the US might explain it. And Sam Preston has done some work to that extent, and it accounts for, a fraction of that divergence of the US. I don't know, I think it was 1.2 years over kind of the last 30 years, but there's still a substantial kind of unexplained fraction. So I think that's a puzzle a lot of people are looking into. And also you can imagine it's hard to know how to best capture things like duration of obesity or intensity of obesity. We don't have comparable measurements, population data sets and trends across lots of these countries. So it's something that is high on a lot of people's agendas, but I'd say it's still a bit of a puzzle.
Amazing. Thank you, Jen. The next question I think would be both for Julia and Jen, but maybe Julia, you wanna have a go at it. So this is a question from Françoise, and she's asking that she's saying that the EU and especially France have better demographics, I suspect, comparison to the US. Is there a causal link with public state versus private health insurances and their respective costs, both at individual and collective level? So what would be the impact of different types of health insurances on the population trends that you both have been describing, and whether that plays out, maybe Julia, in some of the reforms that you are outlining?
Yeah, so interestingly, a lot of the causes of excess mortality in the US that Jennifer has identified are not things that are really very amenable to healthcare interventions. So, it is true, for example, that children die of asthma in the US at much higher rates than they do in other countries. And if more children in the US had access to high quality healthcare, many, many fewer of them would be dying of asthma, right? But for the most part, these big population trends are not super driven by things that healthcare can do all that much about. It is also the case that if we look at the Great Society, we see less of a boost from the healthcare interventions than we did from many of the other kinds of interventions that were part of the Great Society, in part because the big innovation was Medicare. And that meant that people age 65 and older had a government-funded source of insurance. But a lot of people weren't living to age 65, especially poor and minority people. And so at the time, it didn't really affect them. It was also a universal program. And so there's not really a good way to understand whether it had an impact or not. So I think there are a lot of reasons to be skeptical about just how much differences in healthcare across countries contribute to these demographic differences. But there are probably also areas where it does make a difference. And maybe Jen could speak to that.
No, I would largely agree with that. I think a lot of people who, think about this for the first time often think healthcare is explains a lot of it. And I think social epidemiologists and social scientists really think about all the decades leading up and the social exposures leading up to illness as being more important. So I absolutely agree with that. I guess I would say, tying it to Martin's talk, that in the US, to the extent that the kind of precarity and stress about, excessive medical costs or, not seeking care when you think you might need it, I actually think, to me, that might be more of what's going on for contributing to this kind of sense of a lack of safety and security overall in the US that might be feeding in via stress to more of these chronic health conditions.
Thank you. Thank you both. Next, we have a question from Josephine Dixon that I think is for the three of you. So she's referring to recent development in the UK. The 10-year NHS plan just published 2 days ago, I think, puts a great deal of emphasis on prevention and on tech. New health and care tech is seen as a way to mitigate pressures created by aging societies and workforce shortages in health and care, as well as potentially improve health outcome. But how likely do speakers think the introduction of new health and care technology is to reduce or maybe exacerbate, on the contrary, inequalities in the short or longer term? So I think Julia and Jen, you've already started to answer that question just a second ago. But Martin, do you want to say something? And then Julia and Jen, if you want to jump in as well.
Well, actually, to be honest, I think indeed that the other presenters are more capable of us or addressing that question. But let me say that at least what I think is that you hope actually that you can avoid that people have to use the medical health services. So I think even before that, probably you have to do something, right? And that basically relates to also what Julia earlier said, that let's say social programs, and also what Jennifer said, most likely social programs are very important for reducing, let's say, adverse outcomes at later ages. If we talk about medical interventions, I think for when it comes to neonatal health, I think we already know a lot, right? Or at least we are very advanced. Mm-hmm. When it comes to later life health, probably some things can be done, but then actually the larger part of the inequality, I mean, if people reach 80 or 90, then, the larger part of the inequality has already taken place before that. So I think that would be my guess, right? But let's see what Jennifer and Julia have to say about that.
I guess I haven't read the plan, so I don't want to speculate, but I think you're right. The idea that technology would solve these inequalities seems far-fetched to me, that we need to start much earlier in the life course. But, I guess the extent to which there's innovation in the technology of the NHS that frees up resources for all these backlogs and the other problems, I mean, that type of innovation seems great, but I don't expect technology would solve these life course kind of social determinants of health.
So I've mostly so far looked at the data part of the plan, the part that's focusing on health data. And I think there are two ways that more purposeful investment in harnessing health data from the NHS could actually be helpful. So one is that if governments aren't tracking health inequalities effectively, they are flying blind, right? And there are a lot of ways in the UK that there are a lot of ways in which the government's sort of oversight on health inequalities are limited. One of them is, for example, ethnicity is not well recorded in NHS records. And so I think, a little bit more effort put into good record keeping and good record linkage within the NHS and across government could actually be really helpful. And then I guess the one other way that I think this investment in data could be helpful, certainly the conservative government has always taken the position that the NHS is just a treasure trove of data. And if we just let people at it, they would come up with, fantastic innovations that we haven't seen before. And up to this point, it's been difficult to access NHS data and particularly GP data. And, I can see making the case for improved access to data kind of driving innovation. I don't think that innovation is likely to reduce health inequalities. If anything, it's probably going to exacerbate them. But there we go. And then, of course, the big elephant in the room is the opportunity cost of spending this money on data and technology versus spending it on something else that might actually have a more direct impact on people's health.
Amazing, thank you. I'm really sorry. We have like 4 more questions in the Q&A that we won't be able to answer because our time is up. I'm sure it's okay for those of you who still had questions to reach directly to our panel members if you have burning questions that you'd like them to answer. So thank you so much, Martin, Jen, and Julia. I really thought that your 3 talks were very different, taking very different approaches, but showing how they all contribute in their own way to the arc of evidence that we're all trying to build when it comes to describing and hopefully fighting health inequalities. I was quite amazed by the diversity of data that you're all bringing to that, from data about causality, about biological mechanisms, long-term data, as well as archival data to look at policy reform. So it has very certainly encouraged me at least to try to diversify a bit my approaches. And to finish on a positive note, I think the trends are not very good when it comes to health inequalities, but it was heartwarming that there is some cause for optimism, at least with some policy reform, which might be working. So thank you so much to the panel members first, also to Joanne for chairing, for Annabelle for organizing everything. There wouldn't be a webinar without you, so thank you so much. And thank you for all of you for joining us. It was many people joining us today, so it's great to see a lot of interest on this topic. There is a recording that will be made available on the LSE Health website. And this is part of the LSE Health 30th anniversary. So we have today a webinar on health inequalities, but there is a very fun and exciting program over the next few months. So make sure to register to our newsletter to be posted about all the next events. So thank you so much, everyone, and take care. See you soon.